Paraaminobenzoic acid is PABA. And you can see on the one on the your all's left over there, that's what's normally going on. And in between that, where it's coming out the stomach there and the kidney, it's also being absorbed back into the blood as far as the PABA is concerned. If you look out over here, this is showing us that the pancreas isn't working for some reason. You have chronic pancreatitis, or you may have duct blockage or something. And so that stuff's staying in the gut. It's not coming out in the urine, and it is not getting into the blood. So that's what we're looking at. Okay. All right. So as far as exocrine pancreatic insufficiency, remember you've got to diagnose that based upon things. We do everything, right? History, physical exam, your various blood work, doing some of these tests that we were talking about, and if all else fails, you can do an intestinal biopsy and see if we've got evidence that there's a problem there. Okay? If it's intestinal biopsy and you don't see anything in there that tells you it's most likely the pancreas that's causing the problems. Okay? Your therapeutic plan then, if it's exocrine pancreatic insufficiency, what does that mean we've replaced most of the exocrine pancreas with? Connective tissue. Can you reverse that? No. So what do you think you're going to have to do for that animal for the rest of its life? You're going to have to pre-digest the food using your pancreatic enzymes. It's not really that hard. You sprinkle it on there and then give it to the animal, and the animal eats it. That's all you got to do. And they're not that, don't let me say that too loud. Right now, they're not very expensive. Okay, but the more and more we need them, what do you think the companies that make them are going to do? Increased demand does not necessarily mean decreased price, does it? Very often goes the other way. Okay? And missing it one time won't be a problem for the animal, but if you miss it several days in a row, then you're going to see severe problems as far as the animal is concerned. Also, you may want to give some antacids and things like that, because the bicarb that comes from the pancreatic duct and everything helps to neutralize that acid down there, so you may have to give them that. And you actually may have to decrease the acid secretion as far as the stomach is concerned. But a very highly digestible diet is one of the main things you do, and you add those enzymes to that diet not too long before you give it to them, but you don't want to mix it and give it to them immediately, because what will the stomach acids do to those enzymes you got in there? Destroy them, and it won't work. Okay? Now, so here's the fat absorption test that we talked about. It's used to detect and distinguish maldigestion from malabsorption. What are the two components of maldigestion? How about exocrine pancreatic deficiency? And what do you have to emulsify fat and stuff with before the pancreatic enzymes can get it? Your bile acids. Where do your bile acids come from? Your liver. So if you have cholestasis or hepatic insufficiency or something like that, that can cause problems as far as maldigestion is concerned. Okay. Now, the routine fat absorption test, what you're going to do is feed the animal some corn oil. And a normal animal has everything working for it. What should show up in the plasma within about 2 to 4 hours of feeding it to them? Lipemia. Okay. And basically, if it does, what does that tell you? That was everything working all right? If it doesn't, then that tells you, well, I may have malabsorption or maldigestion. So then what do? We go ahead and pre-digest that corn oil and then feed it. If I see lipemia then, what does it tell me my original problem was? Maldigestion. We digested it for the animal and then fed it and it got absorbed. So malabsorption is not a problem, is it? So that tells us we most likely have pancreatic insufficiency. Now, does that sound like it's 100% accurate? No, but it's cheap and it's a good screening test. Okay? So all you got to do is look at the feces and stuff. Look at the blood. Okay? Now, D-xylose. What kind of sugar is D-xylose? It's a complex or simple sugar? Why is that important?
It's easier to digest.
Does the pancreas involved in its digestion breakdown? Do you need the pancreas for glucose to be absorbed and stuff? The same way with this. So what are we looking at? Are we looking at maldigestion or malabsorption? Malabsorption. Because within actually 20 minutes, 20 to 40 minutes, when you give corn oil, give the xylose, you should see it coming into the blood. Okay, not corn, but xylose. And then that xylose will elevate as more and more is absorbed. And so, and the reason, why not use glucose then? Why use xylose?
Glucose has to be supposed to be broken down?
No. What's D mean? That's an isomer, right? Glucose is L isomer. What isomer do you think the body can use? The L isomer. If you give glucose to test for absorption, it's going to be readily absorbed, but what happens as soon as it gets into the blood? Insulin's released, and what happens? So unless you're real quick, you're not going to see any elevation of glucose in the blood. On the other hand, the D isomer, D-xylose, has to be converted to the L isomer before it can be used by the body. That takes time. So in other words, it will be in the blood for a longer period of time after it's absorbed before it can be converted. Everybody follow that? So when you take the test then, you measure the D-xylose levels in the blood at 20 minutes, 40 minutes, or whatever your protocol is, and you should see it elevated. Now if the pancreas is working all right, then it'll start to go down. Okay? And so that's basically, it's going to tell you that you give the D-xylose, and it doesn't need to be broken down, so it means it's not going to involve pancreatic function. So what function are you testing? You're testing the malabsorption portion. Everybody follow that? If you give it and it does not appear in the blood, what does it tell you? It was not done. It was absorbed. And so that's the way we test for malabsorption. Okay? Everybody with me on that? Everybody see why we can't use glucose? Unless you're real quick, you're not going to catch it. Okay? Now, serum, B12, and folate. What vitamin is folate? Tells you right down there, that's vitamin B9. Okay? Alright, so those things are basically the bacterial overgrowth in the gut. Or if you have too much bacteria, exocrine pancreatic insufficiency give you bacterial overgrowth? Because who's using all those nutrients that you've ingested? You can't get them, so what's waiting for them? And what do bacteria do when they get fed well? They multiply. Can that cause more problems? Yes. So we can use these to determine if we have intestinal bacterial overgrowth. Yes, sir.
Don't some of the proteases that the pancreas secretes, wouldn't that control some of the bacteria?
Yes, it does. Yeah. And that's one of the biggest problems you'll see with a lot of pancreatic deficiency problems is bacterial overgrowth. And in time, they can produce enough toxins that can cause more systemic problems and stuff. Okay? So what we do, what's our source of B9? Folic acid. What's our major source? It's the bacteria. The bacteria make it. And that's one benefit. You don't want to wipe out all the bacteria in a gut, okay? They make it. So if I have an overgrowth of bacteria, how much folate am I going to be absorbing? An increased amount. So what's going to happen to my blood folate levels? It's going to go up, okay? So now what about B12 or cobalamin? What's our major source of that? That's diet. But what could be down there in that gut just waiting for it? Bacteria. If I have overgrowth of bacteria, what's going to happen to my share of the B12? It's gone. So we measure serum, cobalamin, and folate. If I have high folate and low cobalamin, it tells me I have bacterial overgrowth. And usually that's going to be some problems as far as pancreatic insufficiency, or this type of thing. Because the bacteria wouldn't have as much nutrients to eat if we were absorbing them, right? And so that tells us we got a problem. Now malabsorption can also do the problem. Okay, but usually if it's malabsorption, you're not going to see increased levels of anything in the blood. So this is a test to basically tell you if you have bacterial overgrowth. Can that be a problem when you're treating an animal for pancreatic problems? Can the bacterial overgrowth be a problem? Yes, one thing they can secrete toxins, another thing they can interfere with that animal getting any nutrients you are trying to give it. Okay, so that's why we need to know that. Okay, so that's the pancreas there. Let's see here. The problem I'm having is that eyes are bothering me, it's hard for me to see. Remember we went through part of our, yeah, thank you for welcoming me back, I appreciate that. When we talked about, and cytology that afternoon, we talked about, cytology, solid tissue cytology of malignancy, and that type of thing. And we're looking through some of the slides here. Y'all remember these slides from that Wednesday, hopefully? If not, maybe don't have to look at them, okay? All right, we went through, come on, Simon. So let's pick up with fluid cytology. Where do you think you get fluids from when you're doing cytology? If you take urine and look at it, is that a type of fluid cytology? Abdominal fluid? It's mainly taking fluid samples from your body cavities, but what about joint fluid would be evaluation of fluid cytology. Basically any type of, what about hematoma? That's a type of fluid cytology. Main fluid cytologies we do, and urinalysis is basically a fluid cytology, if you look at the sediment and stuff. But we do most of our fluid cytologies if we have effusions in the pulmonary cavity, abdominal cavity, or this type of thing. Or if we do a tracheal wash, why would we do a tracheal wash? What's a good way to find out what's going in the lungs? Flush the material that are in the alveoli and everything up and look at it. Okay, so that's the type. What about the CSF tap? What are you evaluating? Solid tissue or fluid? Fluid. So that's the type of fluid cytology. Okay, so various areas you do that. Now, as far as your body cavities of animals, you normally have fluid in there, right? What's the purpose of the fluid inside body cavities? Lubricate. I mean, how do you think your heart would be if it was scratching up inside that pericardial sac all the time? Wall and everything. And so it's for basically to give you movability and everything. Now, generally the fluid's going to be clear and colorless. It has few cells, and if it does, they're mainly the mononuclear cells types, because mononuclear cells are in tissues and also they're out in the body cavity a little bit. Protein values will usually be less than 1 gram per deciliter, and your specific gravity is usually less than 10-15. Okay, that's normal fluid. Okay. Now, as far as when you get abnormal accumulations of your fluid in there, is that rare or does that occur lots of times? It occurs lots of times. A lot of the animals you get in clinics are going to have fluid in different body cavities, particularly the abdominal cavity, possibly the thoracic cavity. And so the ones that we routinely evaluate are abdominal, thoracic, and pericardial fluids, synovial fluid, cerebrospinal fluid, prostatic fluid, and transtracheal bronchoalveolar aspirations. That's when you're looking at the going down the trachea and stuff, okay? And when you examine these fluid accumulations, you're going to be looking at the color, the protein concentration in the fluid, the amount of cells that are in the fluid, and what type of cells those are the main things that we're going to look at. And particularly, it's what's one of the less invasive means of finding out if you've got a neoplasia, such as mesothelioma or something like that. Is to do fluid therapy, okay? And look for those types of abnormal cells. All right? Now, there's 4 basic mechanisms by which you can get fluid accumulating in abnormal quantities, and these are increased capillary hydrostatic pressure. Another means you've got venous stasis. And if you've got venous stasis, the fluid that's trying to get through there, the blood, if it can't get through there, will it start to diffuse out through the vessel walls and stuff? such as with congestive heart failure, this type of thing. Also, decreased capillary oncotic pressure. What's oncotic pressure? So oncotic pull in or hold in? It holds in. And what's the main thing it does it? What's the main oncotic agent? Albumin. What if I have hypoalbuminemia? We're going to lose that and the fluid going to go out? And what do we call that when that fluid goes out like that? What's the term for that? Edema. Okay. Also, if you have increased capillary membrane permeability, such as if you have anoxia in an area that's causing cellular damage, or if you have inflammation, as far as vasculitis or this type of thing, you're going to lose fluid. And also lymphatic obstruction. Because remember, the lymphatics take the fluid back to the vessels, right? What if they're obstructed? Is that fluid going to stay in that lymphatic, or is it going to start coming out also? It's going to start coming out. Okay, so these are the main things that we see with fluid cytology. What's the difference between transidate and exudate?
Clear versus transidate is clear.
Transidate basically is just where the plasma, without all the proteins and things in it, in other words, it's the aqueous portion of plasma, goes out into the tissues. Okay? That's going to be a transidate. A pure transidate means it's going to have the same specific gravity, protein concentration, cellular concentration, as if we took blood and spun it down and just looked at the plasma a little bit. Okay? So that's going to be a regular transidate. Now, what do you think a modified transidate is? Must be one that's been modified, right? And when you see that, if that protein gets out of the blood vessels into the body cavities, can it irritate the body cavity walls, endothelial surfaces, mesothelial surfaces? Yes, it can irritate them. So can that elicit a little bit of an inflammatory response? Also, if you've got problems where you have severe edema that's causing more and more of the proteins and stuff to come, start to come out into the vessel, up into the cavities and stuff, then that is what we call a modified transidate. It has a higher protein concentration than a pure transidate does. But the cell content is not that high yet. So we call that a modified transidate. Now, if that body cavity gets irritated enough, the lining gets irritated enough and all that, can that cause some inflammatory response and this type of thing? So when we start to see a lot more neutrophils and things coming out in there, what's going to happen to my specific gravity when we see that? It's going to go up. What's going to happen to my protein concentration? It's going to go up. You're irritating things like crazy. What's going to increase? Your cellular concentration. So then we have an exudate. Everybody follow me? And so basically, you might start out with the exudate. Again, what if I have a bacterial infection? Is that going to irritate membranes and elicit an inflammatory response? Then that will be an exudate or a transidate. Which one? That's going to be an exudate. Yes, sir.
So can blood outside of the vessel act as an irritant to prepare to
That was going to be, could be a hemorrhagic transidate or hemorrhagic exudate, depending upon whether or not you have activated the inflammatory response. So initially, it might just be a modified transidate. But then if you start getting cells, you start irritating and stuff, it can turn into an exudate. Now, pure edema. Can cardiac problems cause edema and stuff like that? So initially, that is just going to be a pure transidate. But again, if it persists, you're going to start irritating membranes and stuff. You're going to get more protein in there. So you go from there into a modified transidate. That keeps going, gets enough irritation, the cells start to come out, macrophages, neutrophils, all that good stuff start to come out there. Then you're going to develop into an exudate. But if you start out in the beginning with a bacterial peritonitis, you think you're going to go through a transidate stage, or you're going to start out with an exudate? You're going to start out with an exudate. So depending on what's causing it, how long it's been there, almost all pure transudates and modified transudates, if they stay there long enough, you start irritating membranes enough, neutrophils don't respond, white blood cells come up, and then so you've gone into an exudate. If you start out with something that caused activation of the white blood cells in the beginning, you start with an exudate. Okay, everybody follow me on that? Okay, so depending on what the various parameters are of the fluid will tell you what you've got at that point. Now, sometimes it's hard to say, well, this one looks like, in other words, the cell count, usually if it's over 7,000 per microliter in the fluid in a dog, that's considered to be an exudate. But what if it's about 6,000? What if it, so in other words, there's some props over there where it gets a little iffy about which way you're going as far as saying what it is, okay? Now, here's your parameters that we do when we look for fluid analysis, the physical findings, and the transparency. If it's a very clear colorless fluid, what do you think that probably is? Is that an exudate or is that a transudate? Probably a transudate. It's a pure transudate, probably. What if it starts to get very cloudy and reddish colored or all that kind of stuff? It could be a hemorrhagic exudate. It could be septic exudate or something like that. Okay. So we're looking at its color and its transparency. What's a good way to look at transparency?
Type paper on it.
Right, and try to read the paper, read through the paper, right? Now, if you're dealing with a little tiny tube, that can be difficult sometimes to use that, but that's one of the ways to do it. Also, you look at the color. If it's real red in color, what do you think you got in there? Probably hemorrhage. Okay. What if it's green? Could be bile. You might have bowel part